Good evening, everybody. Welcome to those of you who have joined us already. I'm just going to hold on for a few more seconds as we wait for a few more people to come online. But just to say, as we get started, thank you for joining us on a Sunday evening. Thank you for joining the second in a series of webinars looking at issues of health and corruption in South Africa. These webinars have been organized by the Health Sector Anti-Corruption Forum, which is a forum made up of statutory bodies in health, as well as working on corruption, together with several NGOs, Corruption Watch and Section 27. So they have put together a series of 4 webinars, and this is the second in these series. And today's webinar is to allow us to discuss the question of national health insurance and its vulnerability to corruption. And for that purpose, we are, I think, very privileged to have 2 excellent guests who've also given a little bit of time on a Sunday evening. In my middle, I'm not sure if he's in your middle, is Dr. Nicholas Crisp. Dr. Crisp told me a few minutes ago that he started working in the South African health system in 1984, which means that he is a veteran of 36 years working on the right to health in our country. He's worked in the public health sector and in the private healthcare sector. And I think of particular relevance to our discussion this evening is Dr. Crisp's current responsibility over the last, I think, 18 months, 20 months in the National Health Department as the person leading on putting together and taking forward the NHI proposal. So thank you very much, Dr. Crisp, for being with us this evening.
Good evening,
thank you. Also joining us is Sasha Stevenson. Welcome, Sasha. Sasha Stevenson is an attorney, a practicing attorney, but also the head of health at Section 27, which is a non-governmental legal services organization working on the right to health and the rights to basic education. Sasha has been at Section 27 since 2012 and has worked on many, many aspects of the right to health, the Life Esidimeni case, many, many other aspects, emergency services in the Eastern Cape. Welcome, Sasha. And my name is Mark Heywood. I'm the editor of Maverick Citizen, and I am going to moderate this evening's discussion. So before we kick off, now that we have quite a lot of people online, I just want to say, as a kind of out of the blocks comment, that 9 or 10 months ago, national health insurance was in our newspapers, on our televisions, almost every day. It was almost as big a bogey as COVID-19 in the sense of the fear, confusion, panic that it evoked in many people, the polarization that it causes within our society, but also an incredibly important policy initiative that is aimed at equity within our healthcare services, and which is premised upon Section 27 of our Constitution, the right of everyone to have access to healthcare services. But obviously, since COVID-19 came along, we've heard almost nothing about NHI, about the progress of NHI, about the plans for NHI. And so I thought that before we dive in to the specific questions about the vulnerability of NHI to corruption, it's probably worthwhile taking the first few minutes and particularly asking Dr. Crisp to just recap and tell us where we are with national health insurance in South Africa, what has happened in the last few months, and where are we going? So, Dr. Crisp, can you start our conversation this evening just by locating this discussion?
Thank you very much, Mark, and good evening to everybody. So I think people will remember that the bill was tabled in Parliament, and there was a lot of activity thereafter where Parliament called for written submissions, and then there was a call for oral submissions, and there were a lot of visits where members of the committee and the National Assembly went around to provinces to hold public meetings and gather evidence. That concluded just prior to COVID, and we are told that there were over 30,000 written submissions. There were a large number of requests for oral submissions to be made, and the last province was in fact visited by the National Assembly Portfolio Committee prior to COVID. And then COVID happened. So the activities of Parliament have not continued during COVID, and I'm told that they are gearing up and working out how they're going to conclude the remainder of their process now with the restrictions that COVID puts on us. And obviously those are changing over time. So maybe they will be able to have actual physical hearings, but maybe there'll be webinars, and I'm not sure. But there is action again in Parliament. So while that's been happening, in the first few months of the epidemic, everybody put hands on deck. We stopped everything to do with COVID. And the people that I was working with in the preparations for the administrative implementation of some of the COVID activities all went to work on COVID. And it's only about two and a half months ago that I requested that I be released from the COVID team and start to work again on NHI activities. In the meantime, what has happened is that the National Department of Health has had some reorganization. The new Director General was appointed, and the Director General and the Minister have finalized the request to the Ministry of Public Service and Administration for a new organogram that has been submitted. And as a result of the reorganization, they have advertised from the department the post of DDG for NHI, which applications for that post close on Monday. And then hopefully the approval from Public Service and Administration for further posts will be approved. Treasury gave some money and has ring-fenced it and left it for the creation of some key positions, and some 20 to 25 positions should be filled in the next 2 or 3 months. So I think that's where we are for now, and the other answers to other questions can come up later.
Great. And Dr. Chris, can you just remind us just what it is that's on the table? Because NHI is a big beast. Yeah. And it promises everything. This bill that you've talked about and the kind of next steps around NHI, what is it about? Is this the fund that we are talking about? Can you just help us a little bit with that?
Yeah, perhaps it's simpler for people to understand that national health insurance is a financing mechanism for health services, which is adopted by many countries around the world. There are different ways to structure them. We have gone for what we call a single pool, single payer model with the purchaser provider split. So what that means is that ultimately the intention is to have all of us through tax contribute to one single pool, which then has an administration called the NHI Fund, and we'll talk about that, I'm sure, which will be a public entity that is responsible for administering all of this money and paying to providers. The providers, according to our draft legislation, will be both in the public and the private sector, and there's an explanation in one of the clauses, or section 39, which describes what a provider must do to be accredited to be part of the National Health System and paid by the National Health System. So essentially what it will do, it will completely change the way that health services are delivered because of the way that the fund will purchase services. There will no longer be primarily a private sector with 84 medical schemes. There will no longer be 9 separate provincial administrations, each funded out of their own provincial equitable shares. There will just be one financing system. There are caveats and there are small bits about medical schemes outside of this and so forth, but that's the essence of where we're going.
And so what we're looking at the moment and what you've been involved in and what the bill is about the architecture and the establishment of the fund at this point, because the fund is the precursor, if you like, to the integrated healthcare system and the delivery of services.
Yeah, so I'd like to avoid the technical options because ultimately we're aiming for a public entity, and that's the issue that I think worries people the most. So we'll come back to that, I'm sure, in further questions.
We will come back to that.
We can't go there until there's a bill. So the question is, how do you put the building blocks in place when there's no mandate, there's no statutory mandate to set it up? So it's being set up as a branch inside the National Department of Health, and everything except the actual fund can be created. It won't have a board. It will just be under the Director General and the Minister in the department. But the capacity to develop benefits, to work on user management, to put the IT systems in place and so on, previously was not as well organized within the department, and there were many sub-projects. So the idea is to bring it all together and actually create what will ultimately become the bulk of the fund. But the fund itself, the bank accounts of the fund cannot be created until there's the entity to put them into.
Okay. And this will be a fund that obviously controls hundreds of billions of rands at the end of the day.
Sure. Yeah. So my estimate is 3 billion rand a week will go through the fund when it's fully operational, but that will be a gearing up over a long time.
Okay. And I see people are already saying it will be interesting who administers the NHI fund, and concerns about government as player and referee and so on. But before we go there and to those concerns, Sasha Stevenson, Section 27 has been very closely involved with NHI. Can you just comment on what Dr. Crisp said and say what civil society feels about this revolutionary proposal for our health system?
Thanks, Mark. Well, I think firstly, it's clear to everybody that the way that the health system functions at the moment doesn't make sense. The fact that we have a small portion of the population receiving healthcare services in the private sector that has all of the resources, financial and human, and the vast majority of the population receiving healthcare services in the public sector that is under-resourced. And the fact that we then have half of the money that gets spent on health being spent in the public sector and half of the money being spent on health being spent in the private sector. None of that makes sense. So it's very clear that health system reform is required, and the way that we fund health needs to be reformed. The question, of course, is in the details, and there's been a long process of policy and legislative development that's now come to a head in this NHI bill. And as Dr. Crisp says, the bill deals primarily with the establishment of the fund, but it also deals with some of the ways in which national health insurance is envisaged to work in the long term. And I think some of the concerns that have been raised by many people relate to how the fund is going to be governed and managed, how the different processes are going to work out, how participation is going to be ensured, and how transparency is going to be ensured, and then how we transition from where we are now to a system where we have a single purchaser buying health services for everyone from anywhere that makes sense. I think those are the key questions that people have, and frankly, the key fears that people have, both from within the public sector and the private sector.
And are you saying as civil society that if those concerns are properly and thoroughly addressed, that you think that this is a good idea?
We think that health system reform is desperately needed. We're on the track towards national health insurance. In many ways, the word insurance doesn't make any sense. It's not really an insurance system, but a way to purchase services from public and private sector for anyone who needs it certainly does make sense. And so what we've been trying to do as civil society is contribute to the development of this process and make suggestions for how we think some of our concerns can be met and some of the problems with the bill and the way that it's framed can be addressed, and the concerns of South Africans and everyone in South Africa in relation to this massive health systems change.
Right, thanks, Sasha. Just to people who are with us this evening, keep writing on the chat line. We'll study all of these things at the end, including the SIU and others, the Department of Health, who it will help, some of the tips, some of the ideas that you may have. I'm not able to respond to every single issue, but I'm noting these issues, as are our two speakers. So So, okay, we know it's a fund. We know Parliament has to approve the bill. Dr. Crisp, you said, was it 30 billion rand a week or 3 billion rand? 3 would be going through it when things are up and running. So let's get to this question of corruption and vulnerability to corruption. You know, I think you're probably in a worse position, Dr. Crisp, than you were 9 months ago, in that a lot of people will now say, you see what happened with COVID? The moment the restrictions were relaxed, procurement regulations, everything went wild and we've had huge corruption. Is what you are doing not just basically setting up another huge feeding scheme for tenderpreneurs that will ultimately completely divert from your worthy intentions? Dr. Chris, how are you going to manage that? Convince us.
Okay, thanks very much. So first of all, I must agree with Sasha that the devil is always in the detail, and there are issues that need to be debated, and I will not be surprised when clauses are amended and words are changed within the bill. But the essence of what we're trying to achieve, obviously I wouldn't be doing what I'm doing if I didn't think it was the right way to go. And I'm not getting into the discussions around whether private sector is a right or not a right and whatever. I think Sasha said it, that's where we're going. So the question, of course, is what exactly is the fund set up to administer, and how will it be set up so that it's never impossible to plunder, I guess, but that it's extremely difficult. The first thing is the fund will purchase services from providers. It's the providers who still have to purchase the goods and the staff and everything else to run those services. The fund is not going to buy goods and distribute PPE and medicines and so forth. Providers must do that. The fund, according to the bill, is intended to purchase services in two ways. One, from primary healthcare through what are called contracting units for primary healthcare. And there too, yes, I'm aware there are many details that are a little bit fuzzy, and we are obviously working on those and listening very intently to people's inputs. The contracting units for primary healthcare will be the vehicle through which primary healthcare services are purchased from GPs, public health facilities, not-for-government organizations, and other private providers in that space. And the bill moots that they will be funded through allocations made to those geographical units on risk-adjusted capitation basis. Again, risk-adjusted capitation basis, got lots of discussions around exactly what they are and how you put in value adds and so forth. For hospital services, the intention is that some funds, the bill makes provision for two ways to fund the hospital services. The one way is through a global allocation, and that may be for the overhead portion of a hospital, and that the rest of the payments are made for actual services rendered, benefits it's called in the bill. So those will be what we sort of know in the health environment as diagnostic related groups, DRGs, and those details are not in the public domain. We haven't got clarity on exactly the structures of those at this point. It'll take a while to get there. So it's when a provider who has been accredited, in other words, on the NHI's IT digital system, we know that they are accredited to deliver a particular service. When they claim against that service, the NHI will be able to authorize it to pay it. And whether it's every week or whether it's monthly or how payments will be made is got to be in the regulation. So it's not something you put into the bill. I personally would like to see payments be made more frequently so that there's less money in the fund. So what will happen, what happens with government departments at the moment, is every week Treasury pays money into a commercial bank, which is the health department of Gauteng or Limpopo or whatever's bank account, and that could be with any one of the commercial banks, and they then pay their creditors out of those banks. So now instead of the money flowing from the Treasury to the provincial administration through their Treasury to the commercial bank account of the department, that same money will flow through the NHI fund. So obviously the governance of that fund is a worry, it's a fear. And the trick is to make sure that when we design the systems, the digital systems, First of all, they are physically secure. Then they are electronically secure to the cyberspace. Then they protect patients' records and the data that we need. And then they're hard to hack. And in all those business processes, what we are busy with is identifying at which points can either a user, the patient, or a provider, whether it's a hospital or an individual doctor or nurse or physio or whatever, and anybody else try to corrupt the system and to put the checks and balances in so the transaction is just not possible. So if you want to defraud the health system in the future, you'll have to do it from the providers, not from the fund. Thanks.
That's interesting, complicated, but interesting. I mean, watching again the chat, Dr. Chris, people are commenting on some of the things that you're saying. Alex says corruption occurs through licensing, appointments, and procurement. Describing capitation and DRGs as if they are corruption neutral is nonsense. Nati says, you'll be glad to know this, Dr. Crisp has his heart in the right place, but he will have no control over the corrupt elements that will take over the management and administrative aspects of the NHI. The Gauteng Shared Service Center has failed to avoid corruption, and so have all the other state-owned enterprises. Who will be put in place to ensure that the NHI does not fall short of these? Sasha, what do you, are these valid questions? Is Dr. Chris just really being a little bit utopian in what he's presenting us with, or is what he's presenting us with something that can be made to work?
So I think to start off with, corruption, health is very susceptible to corruption, right? It's susceptible around the world. This isn't a South African issue. It's not a COVID issue, although we really saw the sharp end of corruption during COVID. And it's not a public issue or a private issue. It really is very susceptible. And that means that we need to deal with each area in which there could be corruption. And Dr. Crisp has been talking about dealing with potential corruption at provider level and making decisions and developing systems to ensure that where money is flowing to providers, there is less opportunity for corruption. Of course, there is experience with this through the CMS and through medical schemes who say that they think around 15% of medical aid claims can be attributed to fraud, waste, and abuse. So there's a huge amount of problems that the medical schemes haven't managed to work out at that level. I think we also need to be looking at a few levels up, and that's really where our focus has been, and that's in regard to the governance of the fund, the transparency of decisions within the fund, and advisory committees within the fund, participation in those committees and those structures. We need to be looking at this from each level, because if we deal with the technical questions, if we establish the information systems, we establish the payment systems at the local level, we may well deal with some of the corruption, but we still have broad systemic issues that at the same time need to be dealt with.
But Sasha, I mean, you're talking about the governance systems and people who have the oversight, but we have a history in this country that we fill our governance structures with quite often people who are either corrupt themselves or who have a second agenda, and that agenda may be to raise kickbacks for a political party or whatever. So you're segmenting corruption. You're saying there's the provider corruption. You're saying there's multiple entry points for corruption, and we're going to solve this by committees.
No. I'm saying we need to solve corruption at each level.
Okay.
And we can develop all the technical systems in the world to deal with corruption at the lower level, which is fundamentally important, and which is where a lot of the corruption does happen. But we can't ignore the higher level issues, which, as you say, Mark, have been what have thwarted a lot of our progress. And the way that the bill is formulated at the moment, you have NHI fund board members appointed on recommendation of an ad hoc committee appointed by the minister. The board members are then appointed by the minister. The advisory committees are all appointed by the minister. There's no space for civil society other than in a stakeholder advisory committee that has no role in the bill. And the minister can remove members or dissolve the board on what's termed in the bill good cause shown. There's very little oversight by anybody else. And that's not to say that there's anything wrong with this minister. But when we are establishing massive changes to our health system, we need to work the structures in so that they are less susceptible to maladministration and corruption. So those are the kinds of things that really need to be changed, as well as issues around transparency and participation more broadly, which I can talk about later.
Thanks, Sasha. Those seem to me to be some fairly serious design flaws, though. Dr. Chris, do you agree with Sasha? Is the department and Parliament going to be amenable to giving the Minister of Health less power over the appointment of a board and so on?
Well, as a citizen, I would sincerely hope that Parliament takes all the comments very seriously. And I've been watching the few that we do get copied on. And there are some extremely useful inputs that have come through those submissions. But I'm not in Parliament, and I'm not going to play the political game. I have my views. My job is to put as much as possible of the administration in place, and I intend to do that as well as I can. I've been down this road before, and in South Africa with various function shifts, including setting up Limpopo's health department years ago, and in those days it worked pretty well. And that was even before the PFMA. And I've been involved in the National Health Laboratory Service, setting it up. And then there were things that went wrong there as well. But it's not to say things can't go wrong. We must be vigilant. And I agree with Sasha. We need transparency. We need proper accountability. We need to be able to see what we must see within the system. But it's not only at the top. So she's right to address at the top. And I'm not going to differ on that. But all the way through the system, we need to see. We need to see what our practitioners doing. We talk as if only the public sector has problems. If you read the Health Market Inquiry report, there are many problems in the private sector. Many. Sasha's alluded to one, which I think the NHI will reduce the challenge for. And that is if you've got 70 or 80 medical schemes, all with their own boards, with their own actuaries, with their own marketing, their own programs, their own everything, it is so complicated that it's easy for people. If you really want to have corruption, you must complicate the system so that people have to slenter to find a way through the system. And I'll give you legitimate case-by-case of people who have come to me and said, we had to tell stories to our medical aid because otherwise we would never have got healthcare. I mean, it's crazy. We design systems and we put rules in place that advantage the advantaged. And that is not what we're about here. We need to take away the complications. We need to make it simpler, far more transparent. I would like to see every transaction as possible in the public domain, but there's a limit to what you actually can do. And so the cutoffs at what you agglomerate or synthesize in your analysis and put it on the public domain to compare hospital by hospital, practitioner by practitioner, and so forth is also critical to what we are buying with public money, with tax money. So I'm under no illusions that this is a panacea and it's going to be a walk in the park and we're going to do whatever. It is very complicated. Reform takes time. You squeeze on one side of the toothpaste that just moves to the other side. You have to be really careful how you do these things. And in Limpopo, I was taught when I still worked there, you can't squeeze a banana right. You have to do it bit by bit, carefully understanding the process. And I think that's what we are. Administratively, that's what we are about.
But I hear you, Dr. Crisp, and I think you're saying, some people would say, let's just fix all the corruption first, and then we'll get to that. Then let's talk about NHI. I think you're saying we can use NHI to fix corruption, and that NHI is so desperately overdue in terms of an equitable financing system that we don't have any choice. But my experience, and I think a lot of the experience of people who are with us this evening, is that there's a terrible looseness in the way in which public finances are managed. Big sums of millions are dealt with in the way that I would deal with my tens and hundreds of rands in my wallet. I'll give you one example. and I'd like you to comment in relation to NHI and how you would stop this. You know, I recently picked up through the Gauteng expenditure disclosure report that a company that should have been paid 1.9 million rand was paid 196 million rand, and nobody noticed. So 200 million rand or thereabouts could just disappear from the pot without anybody in the system picking that up. And if you look at the Treasury website today, even though I've been pointing this out to them for 3 weeks, it's still reflected that this company got 196 million rand for putting wooden floors down in a tent at Chris Hani Baragwanath Hospital. Now, when you're dealing with 3 billion rand a week, how are you going to prevent things like this from happening?
Okay, so I'm not suggesting for a minute NHI will get rid of corruption. It will get rid of administrative overheads. It will get rid of all kinds of other burdens. But it's incumbent upon us who are building a system to design out as far as possible fraud, theft, and corruption. And we need to understand the risks. We need to understand the processes that lead to those risks. People will try to steal. Patients steal from medical aids all the time, and so do health practitioners. Make no mistake. And people are helping themselves everywhere. I mean, I'm sure we can all give plenty anecdotes of what happens. The question is, why didn't the system pick that up? So the system, I'm not going to give the nuts and bolts of what we're doing on public radio, but on public TV, but exactly what you have to have a system when that tender is awarded, the amount is flagged so that when a payment is made, the bells and whistles go off all over the place to say, you can't load this amount. We already have those things in our systems. If you have put in that the amount is 5,000 Rand for a particular benefit, and that's going to be the payment, it's designed that if that benefit code comes up, you can't get paid more than 5,000 for that benefit. Now, somebody can go and fiddle with the programming or hack into the system, they would be able to change that. But that's the IT structures of how we try and secure the coding and the relationship between the coding and the pricing, etc., etc. So once again, I'm not under illusions that this is a walk in the park. But we talk to banks. They get it right, and people still steal from the banks. They steal from our own personal accounts through the banks. So you can't completely exclude theft and fraud and people who want to take things away from us. I think what we need to do is we need to make sure that we put the systems in place to minimize that and to deal with it immediately. And so in the structure, we have both an internal and an external structure to investigate anything that is flagged as aberrant, and for those mechanisms to work with the SIU and the forum to report immediately when we find that something that has been flagged is indeed not allowed. Because sometimes things get flagged and they are actually allowed. And I agree that at the macro level, where large sums of money are involved, we need to have different governance structures or very, very tight governance structures.
Thanks, Dr. Chris. Sasha, anything to add on that comment, on that point? Yeah, so I agree that corruption happens everywhere, and I don't think, this is a point that's often made. This isn't just a private sector thing, and of course it isn't just this isn't just a public sector thing, and of course it isn't. It is everywhere. It shows the extent of the problem. It says some worrying things about us as humanity, that this continues to be such an issue. I think, Dr. Chris refers to the fact that we've got some of these checks already in our system, and the intention is to improve them. And I think that there are things that we can do at the higher level. There are things that we need to do politically, and there's things that we need to do at the enforcement level and the consequence management level. Because what we've often seen is that even where these issues are raised, and the SIU is starting to change that,
to be dealing with corruption, we've got to deal with it from a preventative perspective, and we've got to then show that there are consequences for this kind of behavior, which has been sorely absent in our health system for such a long time. It's going to be quite an uphill battle, I think, to resolve some of those issues. But we need to deal with the technical solutions, but it's not just about technical solutions, and we need what experience from around the world has shown is that we need the political will to change the way we treat public funds. And that, I think, is what everybody's scared about.
Thanks, Sasha. You know, what I'm scared about is that Dr. Crisp can give us these reassurances, but so often policy is not translated into action. Finding it does not become implementation. You know, both of you have talked about corruption being part of the private sector as well. And I think, Dr. Crisp, you did some research 10 years ago that suggested that actually the split is more or less 50-50 between public and private. Well, you know, we had this health market inquiry that you mentioned, which it didn't use the word corruption, but certainly it found many unsavory practices used to make money in the private healthcare system. I think we spent about 120 million rand on that report. And as far as I can see, nothing has been done about it up to this point. None of its recommendations have been implemented. So why should we believe this time? And Dr. Chris.
Okay, so you know, I'm an eternal optimist. People who, as you heard, I've been in the system 36 years. I've only ever worked in the public sector. I've worked in 9 countries across Africa, and nothing is different anywhere. There's corruption all over. I worked 16 years in Nigeria, who used to have the reputation for being more corrupt than we are. And the bottom line is you can improve things. So what do you want to do? Do you want to sit on the outside and say, I'm a citizen, I'm going to withhold my tax, or I'm going to pay tax and let it just be spent? Or I don't work like that. So I believe that we have to get in the bull ring and we have to fix it. If we leave the health system like it's running now, it's going to implode. The public sector is taking unbelievable strain. There are parts of the health system that we've seen during COVID on TVs and so on that are completely shattered. They just cannot cope. And there are parts of the health system where people are pulling miracles out of the hat every day, doing the most unbelievable work. So, and in the private sector, we hear, you know, this practitioner lost 86% of his income during COVID. This one's hospital has collapsed. Some of the hospitals are sitting at 30% occupancies and so forth. The resources are all over the place, and it's just not working. The HMI report, including people who criticize what I have to say about this, basically painted a picture that if you were the CEO of the private sector, you should resign. It's a disaster, and it's a design disaster. It's structurally a mess. So we can't leave it like that. We can't leave the public sector like it is. And my argument has always been, you don't fix one without the other. Many of our practitioners work in both. We've created a rule in the public service that allows somebody that you and I pay well over R1 million a year to go to work can go at 9 o'clock in the morning to their private practice and not be seen for the rest of the day. I got a blog from a UK volunteer doctor yesterday that talks about he and his wife were the only 2 doctors on duty for a week because the rest were all writing exams and doing their RWAPs and doing this and that. All over. People just do not see anything wrong with that. So Sasha made a point a moment ago. We are a sick society. But do you step back and say, it's okay, it's going to still be sick when I die? Or do I say, this is not okay? It's not okay that I have access to healthcare because I earn a lot of money, but the guy who works for me doesn't have access to healthcare because he doesn't earn a lot of money. If we both got appendicitis, what's the problem? Our wallet or appendicitis? That's the point of departure. So once we've got the point of departure, the question is, what do we as individuals and citizens and practitioners, members of society, members of whatever we affiliate with, what do we do to fix the situation? So we've picked a path. Some don't like it. It's fine. You're welcome to differ. And I've seen some of the comments here. It's the same people who always differ with me, and that's fine. I've decided that I want to be part of the solution, and I've got so long left until I have to retire, and I'm going to throw my weight behind it. And we will do everything we can to block what we have seen happen to defraud, steal, or have corruption. I watch the Zondo Commission as well. I watch some of these crazy things being said. But we can't just say because they happen there, it's going to happen anyway, so we're going to do nothing. That's not a solution.
It's not, and I think we all agree with you, Dr. Crispin, and admire your commitment. But you raised the question that you didn't answer, and I'm going to ask Sasha. What do citizens do, Sasha, to make this, to root out corruption as part of NHI? What do you tell people, like the 120 people who are with us this evening, that they should be doing? That's one question. The second question a number of people have raised, and you've raised, is the ethic. That there's no ethic in healthcare provision amongst many people, which is why the RWAP system, the remuneration, whatever it's called, is so terribly abused. And one person did ask, how do we make sure, how does the NHI make sure that you're not being billed for work that doesn't get done because of an abuse of a system like RWAPs? So Sasha, can you just tell us your thoughts on some of the things we should be doing?
Yeah, thanks. So I think the first thing is get involved. There are some structures within the health system that allow for public participation, and we need to be involved in those. But more than that, given that there's this massive health systems change coming, we need to advocate to make sure that there is public participation in this whole process. We need to make sure that the department and Parliament recognizes what we think is needed, that we want as citizens and people living in South Africa to be involved, to be on the committees, to be able to see the decisions that are getting made, to make complaints through complaints boxes, to raise concerns with the SIU. I think it's not enough for us to sit back and complain, and I don't think, Nicholas, anyone's suggesting that we do that. But then we need to do what we can to take action and to get involved and to participate. On the ethics question, Mark, I think we wouldn't want to create the impression that there is no ethics within the health system. There are incredible people doing brilliant things, and that are doing so honestly and with integrity. The trouble is that we never catch the baddies. we struggle to identify when there are problems, and what we really struggle to do is to provide consequences, to ensure that those people aren't allowed to just continue. And some of the solutions that Dr. Crisp has laid out go some way towards that, but we need to recognize what else needs to happen and to push those things. So for example, the Health Market Inquiry did make all of these recommendations that haven't been implemented, and I think that's criminal, because as you say, we've spent a lot of money on this. There are clear recommendations about what would make the private health sector better, how we manage quality, which is a massive problem in the public health sector as well, but it's also under-monitored and assessed in the private sector. How we standardize that, how we make sure that people who are on medical aids are able to compare medical aids with each other. All those recommendations have been made, and we need to implement those things, because just having a single purchaser isn't going to fix all of those problems, and it's certainly not going to do so in the next 5 years, recognizing that this is a long process. Although the bill suggests that we'll be done soon, we all recognize we won't be, and there's going to be a long time until we have any kind of single payer, even if everything goes to plan. So I think we need to act on some of the recommendations that have been being made for years, and not wait and hope for a single solution, which I think has been what has held the department back for the last 5 or so years, and that really does now need to change, because the system isn't sustainable the way it is, neither in the public nor the private sector.
Thank you, Sasha. And to those of you who are putting comments on the chat line, please continue, because the SIU, being part of the Health Sector Anti-Corruption Forum, is with us this evening, is reading the chat. So any useful suggestions about how we deal with health sector corruption will certainly be heard and be noted. Nicholas, in a discussion earlier this evening, you mentioned to me that you've developed, I think, with the SIU, a framework for fraud and anti-corruption in relation to NHI. Is there anything in that framework that you haven't kind of covered already this evening? Can you just very briefly say a little bit about this operating framework? For example, will there be an NHI police force from the beginning built into the system that can track these cases down, investigate them, prosecute them, make sure that there's action from the very outset?
Yeah, so thanks. So the NHI in the department, as I said, is still in the Department of Health, but we have a joint forum with the SIU where we have been interrogating the processes, and it's the downstream stuff. And I've seen some of the comments complaining the downstream stuff is the small things. I disagree. I think it's all important, but obviously the downstream fraud and corruption and in the system is an issue, and that's where we've been mostly working together. But in answer to the specific question about when we identify that somebody has, or the system flags that something is, I call it aberrant behavior, because it's not necessarily defrauding the system. There are mechanisms from that. In the first 25 positions, 2 of those positions are already being put in place, so that we can have the managers to start developing the standard operating procedures for internal fraud and external corruption, and exactly how we go about it, how we identify it, what do you do when we detect them, what are the processes involved to investigate, and so forth. So right from the beginning, those are very key. I mean, I don't want to go through unpacking all the little bits of details of this is what we're doing in this IT system, and we're using this technology and that technology. Those are things that are obviously part of it and part of a solution. And we learn from other IT forums. There's a really remarkable global forum on all of this, which is facilitated by the WHO that we are part of. So we have been learning for some time how to make things tighter.
So somebody mentioned this thing called the open data procurement system. I hope I haven't gargled it. Will you adopt a system like that, Dr. Chris, or will the NHI adopt a system like that?
Okay, so you can't have one system for a thing as big as this. It would be absolutely crazy. If it collapses, it's like the bank, and boom, the whole bank's down. Imagine if it was all the banks used the same system. That would be absolutely crazy. So interoperability is absolutely critical. And the first interoperability standards were published in 2014. The new ones were consulted. Fortunately, we had that forum, the final forum, just before COVID. And those documents have now been through the legal process. They've dotted the I's, crossed the T's. It's been through the Director General and is ready. The National Council, the National Health Council Technical Committee at their last meeting approved that can now be published and standardized. In the process of that, we have been working with the health information exchanges in the private sector. There are several, some big, some small, and working with various other, obviously in the public sector. There are 42 hospital administration systems running in the country at the moment. Not all of them will comply with these interoperability standards. So it'll have to come down. They will have to change over the period in order to get accredited. But the data within those systems, and for those who are switching, and we hope it'll happen fast, to electronic patient records, it will become easier. But the whole country doesn't have connectivity. So about 20% of all the facilities will not be real-time online, and that is key to a properly functioning NHI. So we are working on processes to get the connectivity improved. There's some quite interesting interdepartmental programs that are going on and talks that are taking place. So there's no one solution to any of this. It's a multiple set of solutions, and some of them are frankly serious obstacles. And we're going to have to find other ways to deal with them, like the connectivity issue. But some of them have got easy solutions. They've been in the public domain for a long time. And I agree absolutely with Sasha. There's no reason why we can't implement them. Okay, let me leave it there.
Sasha, you're agreeing with each other a lot. Civil society is meant to not be in agreement. I'm joking, but Sasha?
No, I think we do agree with with a lot of what Dr. Crisp is saying, in particular in relation to putting in place the systems to deal with corruption at the service provider level and at provincial level. Our concerns remain there, and that's something that we need to watch. But we're also concerned higher up and at the kind of the political process that has been our undoing for a long time in the health system. You know, we saw from the AG's report just this week that there was, what was it, 69 million rand in irregular expenditure across the health sector. That's the Department of Health and CMS and MRC and others last year, up from 37 million rand the year before. Now, not all of that is corruption and fraud, but some of it is. We've got ongoing and serious problems in the system that we need technical solutions for, but not just technical solutions for. And I know Dr. Crisp agrees with that too, but I think we need to focus on the non-technical solutions as well. And maybe that's for Parliament and for ministers, etc. You know, I think the reason that we're talking about this, the reason that it matters, is not because we're tired of corruption as South Africans, which we are, but it's because in the health sector, corruption kills people. Across the world, research suggests that 1.6% of deaths in children are as a result or can be attributed indirectly to corruption, to people leaving early, to money going to the wrong place, to there being no oversight mechanisms. Corruption is stealing from all of us, but it steals mostly from the poor. And when we're putting all of this money into a single pot, and we are trying to orchestrate a health system as a procurement system from the middle to try and get it to work in a decentralized way, there is such huge risk and it has such big consequences. And that's the reason why I think while we agree on some things, we can't stop pushing on the broader level issues and stop demanding transparency and participation for people outside of the technical world. Because also, I must just add, technical decisions aren't value neutral. You know, that there are decisions that get made in systems that may seem like they should be left to experts, but really they affect people, and there may well be important contributions that people who are either working at a health facility or using a health system can contribute. And so I think we mustn't underestimate the value of the experience of normal people in this kind of massive health systems change. This isn't a time just for experts. It's a time for ensuring that we're able to participate in this system.
But Sasha and Dr. Chris, given the importance of ordinary people, the ordinary health user, to the success of this project, do you think ordinary people actually know what's going on? Do you think that they have been empowered yet to be the guardians of a national health insurance system? And what needs to be done to make that possible? Sasha, perhaps you can start on that one.
The answer is absolutely not. It's something that we as civil society have been trying to take on, trying to talk to people about what NHI is, what it isn't, how they can participate, and how it will change things. I think there's been a lot of spin in relation to NHI. You know, NHI is used as the term for any kind of change to the health system. And frankly, people who are using the public health system are looking often just for some kind of change. And so whenever there's any kind of improvement, it's attributed to NHI, when that's not necessarily the case. I think that there's huge need for real information sharing, for honesty and transparency with the public in a way that isn't just trying to get people on side, but is really trying to allow for public participation. You know, we saw in the parliamentary committee went around the country and did these public participation processes and exercises that weren't necessarily about NHI, but were more about garnering support for the idea that is NHI. That's the kind of thing we need to change. And as civil society, we can't do that alone. We need to have more information, real information about what NHI is actually going to look like, so that people are able to participate in decisions that are so fundamentally going to affect their lives.
Thanks, Sasha. Dr. Chris, quickly on this.
Yeah, so I don't think the public even vaguely understands what we're talking about, and I think the information in the public domain is horribly wrong and horribly skewed, and it doesn't touch people's lives. I think up till now, in the major media public domain, it's been a fight between people who have got vested interests. There are those who want to maintain the status quo. There are those for whom this will mean a radical change that they don't want to see. And there are some who argue on an ideological basis. But that's where most of the discourse has been. But if you've worked in the health system, and as you heard, I started in 1984 working in what were the homeland rural mission hospitals in those days, nothing's changed. I get a report the other day from Butterworth Hospital, and I could cry because it's exactly the same as what I experienced in 1984. It's horrible, and we can't allow it that people don't understand how the health system works or get misled by those who want to maintain what they've got at the moment. So one of the first positions that I've asked for in the new structure is a communications manager dedicated to NHI. We get good coverage and we get good support from the communications people in the health department, but they're doing COVID and they're worrying about HIV and they're doing other kinds of things. We need to design and have proper communication strategies. We need to build real alliances with all the civil society groups. For me, if the unions are not on board, they are the workers in the health system. So if unions have a problem with their own behavior and their own way in which they react as employees and as professionals in the service, what are we talking about? So everybody needs to get a wake-up call. And I personally think COVID did that. In the beginning of the NHI discussion, it was the private sector versus the public sector. I must tell you, during COVID, the cooperation from the so-called the private sector was fantastic. People have offered services. Hospital groups have come forward and offered to help. People have constantly said, whatever we can do at cost. And I don't think it's just, bravado or whatever. I think it has been genuine. And we need to capitalize on where the goodwill is. There will always be naysayers. There will always be people who don't want change and who don't want to see things improve. That's fine. But we need to make sure that the general public understand that this is not a foofy, this is not a monster. This is a way that when you get sick, you should not have the burden at the point of care. That's where we're going.
Thanks, Dr. Chris. I'm going to take that as your final comments for the evening because time has somehow run away with us. Before I conclude, Sasha, is there anything you would like to say just as a final word on this issue? Dr. Chris talked about how, in a sense, COVID-19 has reinforced his convictions that this is something that has to happen. Can you say the same? What would you like to leave us to think about?
I think COVID-19 has reinforced a few things. It's reinforced that we need to think seriously about corruption. It's reinforced the fact that we have an incredibly inequitable health sector. There has been some participation and some collaboration between the public and the private health sectors during this period, and it's important. And I think what Dr. Chris raises about trust is very important. Part of the problem before was that, and still now, is that people don't trust in this change. I think the way to get trust is through showing you're working, it's through being transparent, it's through including people in decisions, it's through showing what you're doing, through taking real steps that actually improve things for real people. But you can't do that without transparency, you can't do that without public participation, and you can't do it without real accountability so that people can trust in this system and the proposed change towards a different one.
Thank you, Sasha, and thank you, Dr. Chris. I think, just in conclusion, one of the things that perhaps we haven't talked enough about this evening is political accountability. We've discussed as if technical solutions, however well designed, can fix things for us, and they are very necessary to do that, well-designed systems. But we also have to have political accountability and consequence and commitment to the notion of everyone's right of access to healthcare services, which I don't think we fully have at the moment. I mean, I've seen the former head of the health in the Eastern Cape gets moved sideways after a terrible record of failure and reappears in the Premier's office and is currently directing the COVID-19 response. You know, that is an NHI issue for me, because it suggests that politicians and appointees will continue to get away with murder effectively. So that has to stop. So I want to thank everybody for this evening. I want to apologize and say NHI is incredibly complex. Corruption is incredibly multi-layered, unfortunately, and it's very difficult in 1 hour to traverse NHI and corruption. But I hope that this webinar has given everybody a sense of the issues, of the sense of Dr. Crisp's approach, of civil society's approach through Sasha, and that we will continue these discussions. I'd like to point out to you that our next webinar is on November the 29th, and that is going to discuss corruption in the private healthcare sector. And we'll have people from the Competition Commission, from the Council for Medical Schemes, and the Board of Healthcare Funders with us that evening. So we're going to dig a little bit deeper about private sector corruption that evening, and I would invite you to join us for that. So let me finish just by saying thank you to Corruption Watch, who behind the scenes have put a lot of effort into making this smooth. Thank you to the SIU, who've also played an important role in helping us. And thank you to our two guests this evening. And I think we'll leave it with 2 points. One, we have to kill this corruption because it's killing a lot of people. And secondly, we have to have a carefully thought out radical reconstitution of our health system and integration of public and private, because the levels of inequality that we live with are intolerable and should be seen as intolerable by everybody. So thank you so much, everybody, and good night and good luck, and stay well and stay safe. Thank you. Bye-bye.
Thank you.